What is hypodontia? Hypodontia is the developmental absence of one or more teeth. The etiology of hypodontia is uncertain, but a familial pattern, as proposed by Brooke, indicates polygenic inheritance. This suggests that the likelihood of relatives experiencing hypodontia is influenced by a combination of genetic and environmental factors, each with a modest impact. Introduction. Hypodontia, the absence of one or more teeth, includes conditions like oligodontia and anodontia. Prevalence ranges from 0.08% to 1.55% in primary dentition and 2.3% to 11.3% in permanent dentition. The cause is unknown, but a familial pattern with polygenetic inheritance is suggested. Hypodontia is associated with microdontia, and occasionally occurs without a hereditary link. It's also linked to other dental anomalies. The most commonly absent teeth are the second mandibular premolar, maxillary lateral incisor, maxillary second premolar, and mandibular central incisor. Managing hypodontia presents challenges, with treatment options varying based on severity. A case study underscores the importance of timely interventions, such as the removal of retained primary teeth, to achieve the best outcomes and preserve the integrity of the dentoalveolar bone until implants become viable. Patient demographic. Age: 12 years and 9 months. Sex: female. Nationality: Canadian. The patient has a chief complaint of the missing grown-up teeth and what happens next. So let's go to the case report. A 12-year-old girl was referred to the Graduate Orthodontic Clinic at the University of Western Ontario by her family dentist due to concerns about missing permanent teeth. Her main complaint was related to the absent adult teeth and uncertainty about the next steps. The patient had no notable medical or dental history, and there were no oral or dental anomalies in her family history. Intraoral examination revealed a Class 1 malocclusion in the late mixed dentition, with a 2 mm maxillary median diastema and microdontia in the maxillary left lateral incisor, tooth 22. Despite good oral hygiene and gingival health, radiographic examination confirmed the developmental absence of 12 teeth, teeth 18, 17, 12, 25, 27, 28, 38, 35, 31, 41, 45, and 48. Additionally, significant external root resorption was observed in the retained primary teeth 75 and 85. Let's proceed to our treatment planning. This study has proposed a combined orthodontic restorative surgical team approach. Orthodontic treatment through a non-extraction approach using a pre-adjusted fixed appliance system. After the debonding, tooth 71 and 81 will be extracted due to poor aesthetics. Maxillary left lateral incisor will be built up through restorative dentistry. Implants will be placed on tooth 12 and 45 in the mandibular midline area. Next is the collaboration. This complex case involves the collaboration of orthodontics, oral surgery, prosthodontic restoration. A collaborative approach involving orthodontics, restorative dentistry, and surgery was employed to address the patient's oral health. The primary goals of the orthodontic treatment were to correct malocclusion and align the teeth in preparation for future prosthodontic care. A diagnostic setup was prepared, and a comprehensive treatment plan, incorporating all three specialties, was agreed upon with the patient's consent. Orthodontic treatment, using a non-extraction approach with a pre-adjusted fixed appliance system, began when the patient was 13 years and 1 month old. Prosthodontic restorative needs were regularly assessed during orthodontic treatment, leading up to the debonding process, which was completed when the patient reached 15 years and 5 months old. Following debonding, extraction of teeth 71 and 81 was performed due to poor aesthetics. Conventional orthodontic retainers were initially fitted, with replacement dental units, anticipating long-term implant insertion and the placement of final superstructure fixtures. The orthodontic goals were successfully achieved during both the active and retentive phases, resulting in a favorable treatment outcome. Let's go to our procedure and techniques. First is the diagnosis. This includes thorough examination and identification and X-ray and imaging to assess the dental and skeletal structure. We can see in the slide a clinical view of malocclusion at initial presentation and a radiographic view of the patient's teeth. Second is the treatment planning. Treatment plan was agreed to involve all three specialties, which is a combined orthodontic restorative surgical team. We can see in the slide the patient's diagnostic cast for pre-treatment diagnostic setup. Next is the orthodontic intervention. This includes correction of tooth alignment issues using braces or other orthodontic appliances. As what the slide shows, we can see an orthodontic appliance on the patient's teeth for the tooth alignment procedure. Treatment commenced when the patient was 13 years and 1 month old. The patient was reviewed regarding her prosthodontic restorative needs during orthodontic treatment and before debonding. Debonding was completed when the patient was 15 years and 5 months old. Next is the surgical procedure. The slide shows the clinical view of the patient's occlusion. Due to poor aesthetics, teeth 71 and 81 were extracted following debonding. Next, in this slide it shows the radiographic views following debonding, orthopontomographic view and periapical views of incisor area. Also, in the right side picture shows an orthodontic Holly retainers with dental units used in the interim period between debonding and placement of final crowns. Conventional orthodontic retainers with replacement dental units were fitted initially with a view to the long-term insertion of implants and placement of final superstructure fixtures. The orthodontic goals during both the active and retentive phases were achieved with good treatment outcome. Next is the implant procedure. The patient was followed in the graduate orthodontic clinic until maturation of her gingival unit and completion of her skeletal growth. 2 years after debonding, the patient was assessed in the fixed prosthodontic and oral surgery departments for final management of the edentulous spaces. When she was 19 years old, 3 implants were placed at teeth 12 and 45 and in the mandibular midline area. Due to the lack of dentoalveolar bone in the mandibular midline area, an augmentation bone graft was necessary and was carried out 6 months before implant insertion using bone harvested from the right external oblique ridge. No surgical complications arose and subsequently coronal fixtures were placed in teeth 12, 31, 41 and 45. The microdontic tooth 22 was built up to ensure symmetry with 12. For now, the mandibular left primary second molar, which has good function, is being retained. And next, after the implant procedure, is the patient monitoring and patient education. This involves the regular assessment of oral health indicators, including the condition of teeth and gums, to identify any potential issues and many more. In this slide we can see a radiographic orthopontomographic view. This shows the progress after 2 years following placement of implants and final crowns. The patient, now aged 23 years, continues to be reviewed annually. Let's proceed to the results and outcome. Orthodontic treatment involved significant time, as implants and final prosthodontic restorations had to be delayed until gingival maturation and skeletal development were complete. Good coordination was achieved among all 3 dental specialties throughout the treatment. In cooperation with the patient, a combined treatment plan was agreed to and the patient was reviewed at planned intervals both during active orthodontic treatment and later during retention. All pre-treatment orthodontic goals were achieved without complication. Both arches were correctly aligned, with coincident midlines. And next is a slide showing clinical views of occlusion, patient aged 21 years, 2 years following placement of implants and final crowns. This shows a lot of improvements and a big difference on the patient's overall oral health. Next is the discussion. Association of dental features. Hypodontia, microdontia, supernumerary teeth, and megadontia often occur together, prompting various researchers to explore explanations for these associations. Brooke's multifactorial hypothesis. Brooke proposed a multifactorial hypothesis, incorporating genetic and environmental factors. His model places hypodontia and microdontia at one extreme and megadontia and supernumerary teeth at the other. It explains the observed gender differences in significant microdontia among males with hypodontia. Kjar's etiological variation. Kjar and colleagues suggest diverse etiologies for hypodontia cases, emphasizing the role of peripheral nerve branches. They report cases where tooth agenesis is associated with the absence of the mandibular canal and propose the influence of oral mucosa and supporting structures in conditions like ectodermal dysplasia. Clinical case report. The presented case features microdontia associated with hypodontia, but no family history supports a genetic basis. Clinical and radiographic examinations found no mucosal or bony abnormalities related to Chiar's model. Multidisciplinary approach. The case underscores the importance of a multidisciplinary team approach in both treatment planning and ongoing care. Objectives in hypodontia management. The primary goals in managing hypodontia cases are to improve aesthetics and restore masticatory function, both of which were successfully achieved in this case. Coordination of care. Given the patient's early adolescence, timing and coordination were critical. Orthodontic treatment required significant time, delaying implants and prosthodontic restorations until gingival maturation and skeletal development were complete. Treatment plan and coordination. A combined treatment plan was agreed upon, with regular reviews during active orthodontic treatment and retention. All pre-treatment orthodontic goals were achieved without complication. Complication in bone levels. A complication arose due to low pre-treatment bone levels in the mandibular midline area. Further bone loss occurred post-extraction, necessitating dentoalveolar bone augmentation before implant insertion. Consideration for tooth extractions. The timing of mandibular primary central incisor extractions and subsequent implant insertion is discussed. Despite complications, the overall outcome remained stable, with aesthetic replacements placed on retainers for patient satisfaction. Lastly, the conclusion. Effective management of marked hypodontia requires a well-coordinated, multidisciplinary approach with precise treatment planning, particularly in adolescent patients where optimal orthodontic control is feasible. Multidisciplinary collaboration is essential for treatment planning, emphasizing space management and utilizing diagnostic setups for evaluating tooth position. Timely primary teeth extraction, ideally coinciding with implant insertion, is crucial. Associations between hypodontia, microdontia, supernumerary teeth, and megadontia involve genetic and environmental factors. Brooks' model suggests a spectrum, with hypodontia and microdontia on one extreme and megadontia and supernumerary teeth on the other. The case report underscores the importance of a multidisciplinary team throughout treatment, achieving aesthetic improvements and masticatory function. Despite complications in mandibular bone levels, requiring dentoalveolar bone augmentation, the overall success highlights ongoing collaboration and planned patient reviews. We extend our heartfelt gratitude for your attentive consideration of our case report. Your thoughtful engagement reflects a valuable contribution to the exchange of knowledge and advancements in our field, and we sincerely appreciate your time and attention.